Good afternoon, one and all. This is Kevin McGinnis, who, on behalf of the National Association of State EMS Officials, the National Organization of State Offices of Rural Health, and the Center for Leadership, Innovation, and Research in EMS, is bringing you the November 2016 edition of the Community Paramedicine Insights Forum. We're excited today to revisit Oregon, where we've been at least a couple of times, in fact, once before, featuring some folks who have been doing exciting work for a few years now in mobile integrated healthcare, the Tualatin Valley Fire and Rescue Service, and they've come a long way and are going to be reporting on where they've exactly gotten to. But we're going to take a broader look as well at progress made in coalition building along the mobile integrated healthcare highway in Oregon. And in fact, we're going to be calling this session Burning Bridges Traveling Along the Oregon MIH Trail. And today we welcome, with great pleasure, Paul Bollinger, who is Senior Project Manager with the Health Share Oregon in Portland, Oregon, and is point person for community paramedicine within that organization. He'll be helping us explore the coalition building that has gone on within Oregon around this topic. And then we are very pleased to have with us Mark Stevens, who is the Division Chief of Mobile Integrated Healthcare for Tualatin Valley Fire and Rescue, as well as Charmaine Kackler, who manages that program for the fire department. So I will tell you without further ado that this is going to be a great program, and let us just get into the meat of it. Folks, it's all yours.
Okay, well, thank you, Kevin, so much for the introductions. And I'm Paul Bollinger with Health Share of Oregon. It's my pleasure to be joined today with, as Kevin mentioned, with both Mark Stevens and Charmaine Kackler to discuss mobile integrated healthcare in Oregon. Mark, do you want to kind of explain our first picture and where we are, and then we'll kind of get started?
Oh, a little history. About a couple of years ago, Tualatin Valley Fire and Rescue Chief Havener and I gave a overview of our CAR program at the time, and now this is kind of a follow-up to that. We use the capacity of the CAR program, and we can, after Paul covers some of the statewide initiatives and how far we've come, and some of the joint ventures, I will catch us up on those pieces. So this takes off with a live picture that we had taken off a burning bridge, and we thought that was applicable.
Thanks, Mark. So before we get started, the whole idea around the coalition building was to really look at what are the existing bridges and silos that are there, and let's start burning them down and seeing what's different. But before we get there, there was a dark cloud over healthcare in Oregon prior to the Affordable Care Act. We had a lot of just confusion around the system. It was really fragmented. And as Affordable Care Act came in, the healthcare system was a number of puzzle pieces, if you will, for Medicaid. We had, state money came in, the state administered mental health and medical care. It was some fee-for-service that was out there. We had pharmacy, X-ray. All these things are in just different pieces. So under the great experiment that we've had, Governor Kitzhaber and others created what were called the coordinated care organizations. And coordinated care organizations take in all the aspects of the provision of the Medicaid healthcare system and really focus it back towards the community. So flash forward to where we are today. We have 16 coordinated care organizations that have now led 90% of the Oregon population now has some form of insurance, both commercial and Medicaid. So this is a significant increase in coverage prior to ACA. And each of the coordinated care organizations really look at the way the healthcare delivery system works at the local level. So what you'll see is, I explained a little later here, of the diversity of our population base. What happens in Metro Portland is going to be very different than what happens in the eastern part of our state. But the really key piece is you have healthcare providers and healthcare facilities and plans and communities all working together to focus on those preventative issues, disease management, which results in health equity outcomes that are best for the community. So a little bit about Oregon. We're a significantly rural state. A lot of people don't think about that. Sometimes I think we forget about it ourselves. Our primary population areas are the areas in red and orange on the map that you can see before you. In the upper northwest part of the state is Portland. Our CCO, Health Share of Oregon, is the largest CCO in the state, and we cover over 240,000 Medicaid members, providing both physical health, mental health, and dental care for the Medicaid population. The other 16 are spread throughout the states. There's some overlap. In Oregon, in Portland, there's actually 2 CCOs to be able to cover that. So there's a total Medicaid population of about 310,000 in the metro area. And we call the main population base is along Interstate 5, which is the big north-south highway in the western United States that runs from the Mexican border to the Canadian border. So most of our population base is there. As you go over to that next, kind of in the middle of the map, Bend, Oregon, is on the east side of the Cascade Mountain Range. And moving eastward from there, there's a lot of just rural areas or just plain frontier areas. And as we started thinking about community paramedicine in our state, we really had to have a better understanding of what is the distribution of healthcare providers. So Tualatin Valley Fire did a study a while back looking at what is the percentage of non-EMS healthcare providers versus EMS healthcare providers in the provision of healthcare in some of these counties. As you can see, going back to the previous map, in population bases that were in the orange and reds, were obviously correlates that there would be more non-EMS healthcare providers. But you're looking in the rural areas, EMS is the primary healthcare provider in some of these places. And in some counties, like the northern part of the map there, in the middle of the state, Sherman, Gilman, and Morrow counties, EMS is basically the only healthcare provider. You look down in Harney County, Lake County, the distances for healthcare providers, there may only be one Medicaid provider or even one pediatric provider in the entire county with significant transport times. So as we started thinking about coalition development and building this as a statewide initiative, we had to think, how can we best bring healthcare to those with the greatest need? And our EMS providers were an untapped resource in some communities, or a low resource that we could go ahead and look at as providing that bridge care between the primary healthcare provider and the EMS. So in the spring of 2014, HealthShare brought together a group of providers, healthcare facilities, legislators, policymakers, CCOs to just get all in one room and say, hey, EMS is this resource. Have you thought about how you would incorporate that into your community or in your CCO? So from that, a healthcare coalition for EMS was born. We have now currently over 50 members covering all aspects of the healthcare delivery system. We initially had 3 primary work groups. We had a financial sustainability work group and a 911 nurse triage work group, and then our community paramedicine work group. And these work groups were initially focused on the metro area of Portland. But as time went by and we really saw where the greatest needs were, we really have focused and honed in on the community paramedicine work group. And that has worked as a catalyst to attract other people from around the state to join this. So now we're covering all the way down into our southern borders of our state up against California to out east in the rural frontier areas. And now we have over 20 community paramedicine MIH projects that are going around the state. And as you all know, working in MIH and community paramedicine, if you've seen 20 projects, you've seen 20 different projects. So really focused on community-based in a variety of different delivery modalities. We have a leadership team of within this work group that's made up of a EMS provider, a county regulator, and a payor. So that reporting to them are 3 other subcommittees. We have an operations subcommittee that's looking at protocol development and ways that MIH will operate within our state. We have a data subcommittee, which I'll talk more about later. And then we have an education subcommittee to provide continuity of education. And the creation of these subcommittees were intentional in that we wanted to keep the way we provide MIH and community paramedicine throughout our state to be the same. So whether you're in Portland or if you're in the southern parts of the state, the forms that are used, the data that's collected, the education that's provided, the protocols that are developed will be similar, if not the same. So when we start looking at how is your comparing programs, we can say, we're all working on kind of the same board. So getting rid of some of the silos that were originally out there around, this is our data we don't want to share, these are our forms that we don't want to share. We're really encouraging folks, hey, pioneers that we are here in Oregon, we've blazed this trail before. Let's go ahead and share the forms that we're using before and using the same forms of data collection. So this is our travel log of Oregon. This is Crater Lake, and a lot of our projects, our initial pilots were islands, and they had a lot of small ends and small focus areas, and now a lot of these have graduated into full-grown programs that are sustained, and we'll talk a little bit about some of those right now. So each of the red dots represent active or soon-to-be active programs around the state. So as I mentioned earlier, there's about 20, so we have coverage out at our coastal areas, the interior, high population density areas, and then moving out east. Each program is, as I mentioned before, is different. They can be a fire affiliated, they can be a private ambulance affiliation, they can be driven by payers, hospital-based. And some samples of that include out in Redmond Fire, which is in the central part of the state. This is one of our first projects. They've been working really closely with one of their local hospitals and actually have moved outside of their fire district and are providing care in other areas. Lane County Fire Authority did a completely different spin on it. They used a bricks and mortar approach and had community paramedicine clinics within a centralized area in their community of high need. So they brought the community paramedics there and treatment was provided instead of doing the more traditional or more well-known house call type visits. Portland Fire and Rescue, in our largest city in the state, has looked at high utilizers of the system and has tested a couple different concepts in alternative destinations. And then one of my personal favorite projects is the West Valley Fire Department, which is a very small department in a rural part of the state, which is actually working fully sustained now. They have two FTEs assigned to community paramedicine. They're working very closely with not only their CCO, local CCO, but also their hospital system. And there's tribal medicine. There's an Indian tribe that's really close there and working with the Bureau of Indian Affairs Health System to be able to feed into that, working with a local hospital to be sustainable. But within all of these projects, the biggest issue is we need to have some kind of data that we can collect. So back in the spring, or early spring, we started having discussions within our work group about let's look at data as a whole and what's happening around, what are we collecting? And we were finding out that we had a lot of ends out there that were really small, projects that were only seeing 10 people, 5 people. And I was able in October with some funding to be able to pull to the main providers. At that time, we're about 10 different groups in both Oregon and Southwest Washington, and using one of our academic partners, the Oregon Institute of Technology's EMS program, to agree on a list of data points that we could all say, yes, we're willing to collect this. We had a student research team at Oregon Institute of Technology that was able to do a lit review and look at those data points and then map them and crosswalk them to existing NEMSIS sets. So we weren't going to put an additional burden of data collection by saying, hey, you're already collecting this data in your emergency side. Think about collecting the same data and reporting it on the MIH side. So we also expanded that to talk to both the national groups. We collected data points from the MIH Measures and Outcomes Group, from Ada County in Idaho, MedStar in Fort Worth, NEMSAC, and as I mentioned earlier, within NEMSIS. So since October of 15, as we went into 16, we had the paramedic research team start working in collaboration with data analytics specialists at HealthShare to define acceptable responses for data, what would work and really what would be reported and could be reported out. We created a front end that we started putting in doing some test data to be able to validate it. And then we re-engaged with data analytics again to say, okay, now that we have this dummy data to play with, can we really validate this to come out with some statistically significant answers to the questions we're answering or asking? So again, we engaged with health informatics folks at the university to start designing and building our end product. And that's kind of where the process that we are now is, what is the future going to look like if we keep this as low tech as possible? We know there's a lot of off-the-shelf opportunities, but we also work, as you saw in the earlier maps, we have a lot of frontier and rural areas where they're primarily volunteer-driven departments and organizations, and to ask them to engage in purchase of a large off-the-shelf project, how can we keep this as low tech as possible? So, as I switch slides. So within our data set, we wanted to keep it really uniform. We already know that folks are collecting data as part of the normal day-to-day business of demographics and the referral source. I think these are just areas that we're all interested in. But we also added in sections around ADLs and nutrition. And then within nutrition, we even looked at it one step further and talked about food insecurity. Because if we're going to look for funding opportunities, it's going to have to be outside the normal areas. And we thought if we had food insecurity questions or oral health questions, we can really engage with our local public health departments at the local level, county level, and at the state level, and being able to have that data. Housing is a big issue right now in the Portland area. We've been looking a lot at what the housing situations are. And then transportation. We're fortunate enough in our state that our Medicaid benefit covers non-emergent transportation. But how can we integrate that transportation benefit into some of the needs of our community paramedicine folks, getting them to their appointments? That would be a good thing. So if we started looking at this whole full picture approach of what is needed in data, I think it gives us a much stronger and more robust argument when we start going to the payer groups or other folks to say, okay, now as a state or even as a local community, we now have an N large enough and robust enough that we can substantiate our claims that, hey, this is actually making a difference. But again, we really wanted to keep this low tech. We wanted to keep it as low cost, increase the importance of having good data collection compliance. Again, having some of these smaller departments, if we can keep looking at data is a fun thing. I know I'm kind of a data geek, so I always like to look at it, but encouraging them that, hey, it doesn't have to be some real expensive endeavor to engage with. You're already collecting a lot of this data, and if we can be able to get as many people working within our state around the same data collection methodology, we should be able to have a pretty robust data warehouse that we'll be able to share with both our state colleagues and others, other payer groups. But the key piece of this is accessibility to everybody. So I think I'll throw this next one over to Mark.
Yeah, a little background on the legislation and politics that each of us deal with in our states. Oregon, we have chosen to stay within the current scope of practice. It's a different role, but pretty strongly reinforce the message of staying within our current scope. We operate under the Oregon Administrative Rules that right now it's pretty loose, but it's under the non-emergency care of the non-emergency patient that community paramedicine can operate. We recognize that as this firms up across the country and for patient safety, there will be more standardization and rules written into place. And we already have the connections and discussions going on to form a work group once this matures a little bit further. So we're able to operate within there and not held within constraints of, like some states, of, well, you got to be within the pre-hospital 911 definition. We at least can operate outside of that. One thing we did early on, knowing that home health would feel a threat, we met with the lobbyist and answered all their questions. And now home health is actually one of our best advocates statewide. We find patients outside of our scope of practice, and we refer them out through the PCP, the primary care physician and case managers. We co-treat patients, both home health and community paramedicine, and we make sure that we're on the same page, on the same treatment plan, and don't visit at the same time, those kind of things. So Some of those we took head on, and we still keep educating people, as all of us have across the country with each time that comes up. But we'll have some more legislation to come probably in the next couple of years. As far as Tualatin Valley Fire and Rescue, the programs, we started with the cars that we have, the Toyota FJs, 6.5 years now we've been running calls. And we started with the hypothesis of, what could one paramedic firefighter, what kind of call types could they run, both fire and EMS? So while we were running those kind of calls, we were able to use the capacity of these cars and those paramedics with some extra training and start exploring some of the gaps and assess where we could be needed in the community. The picture here is with a hospitalist, a licensed social worker, and a community paramedic in front of Providence St. Vincent Medical Center. One study we did for a year, an IRB, Institutional Review Board study. We learned a lot. It didn't change much on the readmission rate that was the goal, but we learned a tremendous amount that we took into following studies, and we're better able to target the triple aim and those things for our customers. One of the areas that we explored was putting a paramedic to ride with 10 10-hour shifts with a specialized mental health response team with the sheriff's unit. So the MHRT, or mental health response team, was a specially trained deputy sheriff along with a mental health licensed social worker. And we ran with those people at different times through EMS, but typically if they find a medical issue, they just send them to the ED. And we thought, what would be the potential need that we could evaluate to put a paramedic with them? And in those 10 shifts, they saw 22 patients and calculated they saved 3 hospital admissions, and they canceled the multitude of EMS providers, staging, waiting for something to happen. So some were treated on the scene, one went to a mental health hospital via police instead of ambulance, and only one was transported by EMS to an ED. So we knew mental health was a large issue. This opened the door and really showed us it's a much bigger issue than we realized. There's one other local county that we've been working with, both AMR and Clackamas Fire District, where we're looking at frequent callers and mental health as well. So there's an area that needs further exploration.
Good afternoon. As we went through these pilots, we started another pilot with a local hospital, and we were looking to assist them in decreasing readmission rates. And so during that pilot project, we focused on the specific types of patients that we were looking for, mainly CHS patients and COPD patients. But we also started to get referred to other types of patients, and not all patients, of course, have just one chronic disease. They could have multiple. So we saw diabetic patients as well. And then the other section that you see in the slide, it was a multitude of things that could be like a joint replacement, or they just needed to be seen because they were having multiple falls in their home, or they were having medication issues and they weren't able to, follow up on that. And so we would go out and help the patients with things like that. And so in this project, we had 123 patients, which led to, next slide please, which led to this slide about our readmissions. So with 123 patients, it was interesting, about half of the patients refused or declined our service, so they became a nice control group for us. And we monitored the outcomes of those patients, and of those 60 patients, they still had an average readmission rate of about 23%, which was the going rate at the time for readmissions. And then after we saw patients, next slide please, after we saw patients within our MIH program, which were 63, so really close to 50-50, we saw that the readmission rate for those patients was around 6%. So that led to roughly a 17% change in readmissions for those 123 patients. And the thing that we found through this project, besides that it helped to decrease readmissions, next slide please, is that we just had great patient satisfaction scores, and that's part of that triple aim that we were trying to hit. And so we work together with this particular facility, and it ultimately now has led into a sustainable project, which is a public, private, and hospital-based project that we all partner together.
So just to give you some insight about a project that we're doing here in the metro area, I kind of need to let you know what the ground is for us in the metro area of Portland. We have 21 first responder agencies. We have 4 public safety answering points for our 911 system. We have 2 primary ambulance contractors, 2 CCOs, and a population of over 2 million. 310,000-ish are Medicaid population. So HealthShare is taking the approach of doing a more systems and institutional change approach to MIH. HealthShare engaged with 2 of our partner organizations, Providence Health and Services and Legacy Health, which are 2 of the largest providers that are represented by 7 hospitals in the metro area. And we're working in 2 separate counties in Washington County, 2 separate counties primarily, and touching our third a little bit. Washington County is a mix of urban-rural and is focused with Providence Healthcare and Tualatin Valley Fire with kind of a unique project with a Heart and Vascular Research Institute targeting those patients who are at risk for readmission or high utilizers of the ED, which have cardiac diagnoses. We also are working in Clackamas County, which is another mixed urban-rural, but it is a large rural mix, and we're working with American Medical Response and Clackamas Fire District 1, where they're visiting folks also in the Providence system and some smaller feeder hospitals, but folks that are really more challenged by their rural locations. And they're working with folks on 30-day readmissions of the CMS, risk diagnoses, high utilizers of the ED. And then Legacy Health Systems partnered in the Multnomah County, more urban core area with Legacy Health and Metro West Ambulance, working on folks that are high utilizers of the system, but also a lot of our members have a lot of behavioral health issues, so that tends to have more of a focus with that group. But all these are grant funded by HealthShare to hopefully move the pin a little bit about the 30-day readmission rate in ED while focusing on both behavioral health and cardiac. We're all using the same forms for referral, the same patient care reporting, the same data set. But I think the highlight of this, and the reason we're kind of calling out this particular project, is we're looking at institutional change and looking at those bridges that we talked about at the beginning of our presentation, that burning old bridges but maybe even building new ones, seeing how changes are within the healthcare delivery system and the institutional side, that recognition of EMS as a key player in this and as a real true provider of healthcare, not stepping on the toes of their existing home health benefit, but working collaboratively with visiting nurses and even our community health workers in our local community. So HealthShare has been very impressed with the level of cooperation. These are all 4 organizations that are listed here have very separate scopes of work, and having them come into one room and all work together has been really gratifying and beneficial for our member population.
As Paul said, it's very much a partnership, and as we found that, we talk a lot in healthcare about the silos that need to come down, and EMS has been a silo as well, that we're finally communicating with our healthcare partners and making things happen. Some examples, whenever you start into programs like this, as we've heard from other programs, many stories. One story that hit home was a elderly male that needed some orthopedic surgery. And the surgeon would not do the procedure because there was dental issues, and severe dental issues, of course, is a high risk for the surgery. Well, the patient's insurance would not cover his dentistry work. So a multi-professional group got together as case managers and got the right insurance for the gentleman. He then got his teeth fixed, then followed by the surgery, then followed by community paramedic services with what we normally do to get him back on his feet. And then it was turned over to community health workers from that point to monitor his progress. and he's now ambulatory and living a full life and moving forward. A local health clinic called up and said, hey, we have a bariatric patient that needs a 12 lead. Would you do that for us? And we thought, you just think of the risk of multiple units going and moving a patient to the hospital or someplace, and the expense for the return trip and the 12 lead. Within an hour, a community paramedic had run the 12 lead, transmitted it, and was discussing care with the provider on the phone. So that was a home run for sure. She had a new onset of an arrhythmia that was treated at home. Frequent callers are something we all deal with. They're waiting with their suitcase and many, many needs. Some of them are medically based. Many of them are not. Patients with as many as 400 calls for EMS. We have worked together with many, many partners, including the insurance providers and the payers, hospitals, clinics, mental health, and actually changed the response protocol for EMS and eventually moved the patient to an appropriate facility. So it's very, very much a team effort and a community effort. No one agency or one place can meet those needs, as we find out. Our current emphasis is mostly transitional care, post-hospital discharge of high-risk patients. Hospitals are getting very, very good at identifying patients that they just expect will be readmitted, and they're giving those type of patients to MIH. A little bit too good sometimes. We're finding some patients that need palliative care and hospice and maybe should have had a skilled nursing facility from the get-go. We recently had one where the paramedics' first visit found the patient was too frail and needed to be in a skilled nursing facility. And rather than go back to the ED, the community paramedic spoke with the primary care physician, and they were able to go directly by Uber, actually, to a care facility with the patient, and the private physician met the patient there, which was a home run for everybody involved. We're beginning studies and starting to see patients out of cardiovascular clinics and hospitals looking at post-STEMI, post-AMI, at the benefits that can be there. Because when you look at most of the hospital-to-home programs, there's a lot of phone calls involved, which is good, a lot of education in the hospital. But as we all know, when you get into the home, you find those barriers directly, and you can help get those fixed. So things like mold in a respiratory tubing you don't get on the phone call, but we can actually get fixed. Cardiovascular clinics, heart failure is a big emphasis of late, and a newfound interest we're finding from skilled nursing facilities, driven partly by the incentives of the penalties that they get if the patient gets readmitted. So some patients that go from a SNF to home, some of those transitions starting to show some interest in MIH.
And so what a paramedic does in our programs, which we've already said, we're trying to keep some of these program elements the same throughout all the community paramedic visits, so the payers and whatnot can understand, what does it mean for a community paramedic to go into somebody's home. And so the first thing we do is we have to get the referral, and the referral will come to the different coordinators of the different programs, and then that person will get the medical information that they need for the patient, make the contact with the patient, make appointments, and then send the paramedics out to the house or the home. And so when the paramedic gets there, one of the big things that they do is a home safety evaluation for the patients, just to make sure that they're safe in their homes, that they don't have fire hazards, that they have, shower bars, non-slip things in their tubs, they don't have rugs all over the house and cords and, the like. And then they, on the final visit, will also review that environmental assessment to see if there's been progress in making the home safer, and we can also come up with other partners to help us with patients. We had a VA patient who didn't have home bars in his shower, and so they went out and they put the bars in the shower for them. So we have partners in the community that can help us with making the homes safer as well. And then we always record their activities of daily living when we get there on the first visit and the last visit, because we're hoping to see improvement throughout the visits that we see and the patient. And right now, currently, most of our projects, we see the patient for a month or once a week for 4 visits total. And so we would record the ADL on the first one and the ADL on the last one. We do a lot of medication inventories and make sure that to help patients be more adherent to their medication regime. We do this on every single visit that we go, and we found that about 1/3 of our patients have some kind of medication issue, don't want to take their medications, don't have their medications, don't understand their medications. You know, there's all different barriers to the pharmacology that our patients see. So we work a lot with them on that. We always do a physical assessment on every visit, which could include, glucose checks, SpO2, vital signs, lung sounds, things like that. For patients that are required for weight monitoring, we help them maintain a log for their physicians of all their weights. We help get them scales if they don't have a scale, so they can log their weights. And we kind of do the same thing with their blood glucose and levels and whatnot. So they actually have all these numbers written down, so when they go to their PCP, they can review them. We've done 12 leads as ordered, or EKGs, to help us decide if a patient can, stay home. Do they need to go to the ED? Do we need to call the doctor? So that's always been a helpful tool. When patients get out of the hospital, they have a care plan and after visit summary, but most of them don't really understand what that care plan is, and so the paramedic will reinforce whatever is in their after visit summary and help to make sure that they review that plan, understand it, and in that process, if there was any educational materials that were given out to the patient, the paramedic would review those, and if they didn't have them, we can reprint them and get them to the patient so they understand whatever they are. And one of the other big things which we find helps decrease readmission rates is that they have appointments with their PCPs, and that should happen within a week, and that they have transportation to that appointment, the appointment's made, and everyone is on board with getting them to that appointment. If we see problems in the home, the paramedics commonly call the PCPs and case managers and work with them to resolve any barriers that they might find. And then we keep track in our database all the things that the paramedic is finding, if there's environmental issues, if there's home equipment issues, medication issues, things like that. We keep track of that in our database so we can move forward and figure out ways to better serve our communities. And so that's pretty much what they do on a visit. And again, most commonly they go once a week for 4 weeks, and that's what we do.
So some of the innovations we have in progress, I think Mark has already alluded to. We were looking at ride-sharing options for transportation. Even though we have a non-emergent medical transport benefit in our areas, particularly the urban areas, that benefit is highly used, and sometimes it's hard to get a non-emergent transport, but Uber and Lyft are very prolific in our service areas, so we're able to engage with them to transport our folks to their next medical appointment, or even as the case that Mark alluded to a skilled nursing facility. One exciting piece of data and reporting opportunity that we have in the Oregon area is what's called Pre-Manage. Collective Medical Technologies out of Salt Lake City has a program called EDI, the Emergency Department Information Exchange, to which every hospital in the state of Oregon and Washington are linked. And so we're able to track patient movements through hospitals. So it's been really helpful as we're doing our assessments of our patients beforehand to see which hospital systems or hospitals they're visiting and the reasons to why they're doing it. This is live access. Our partners and from the payer side and the healthcare systems share data back and forth, so we can see in real time when patient Smith shows up at hospital ABC. We know exactly when they've been arrived at the hospital. We can get a real-time notification via email, text, or fax that states the patient's there, what their admission diagnosis is. We can also set up defined cohorts within pre-managed to where we can follow a number of different patients for a fixed amount of time to see if they will go to the ER. Again, this is really great for monitoring those that are high utilizers of the ED system. For some of our more creative members that move around to different hospital systems, we're able to see that all as one globally. We're able to keep an eye on trending of what patients are doing. We can see spikes of usage in different times in different areas, and we can be a little more proactive in the way we respond back to them.
And another along those lines is our EPIC system, and EPIC is an electronic medical record that is used by I'd say the majority of our hospital systems here. And we have been able to sign agreements with the hospital systems for what we call read-only access into the patient's electronic medical record. And that has been very helpful to us to understand, what some of their medical issues are, some of their barriers. We can see case management notes, social work notes, if nutrition, medications, anything that's in that electronic medical record. And so we use that EPIC system a lot when we get a referral, and it's been very helpful. And now our community paramedics also have access to the EPIC system in a read-only fashion, and so they can monitor their patients like right before they go out on a visit. They can get into EPIC and see if there's been any updates from the PCP, or if they had gone to the emergency room and things like that. So our ability to have access and with the permissions of the hospital systems has just been wonderful for our programs.
Our 911 protocols come from a partnership effort in the area, the Protocol Development Committee. And it started with 3 counties. It's now expanded to many, many more counties. And we're taking the same or similar approach for MIH protocols, that we were just started to collect them through our coalition that Paul described earlier, the Oregon MIH Coalition. And we want to keep patient safety first and consistency as much as possible. So we're looking at best practices and as many protocols as we can find, and want to streamline and have one set that we can forward that can be used by members if they want to start a program here in Oregon to add some consistency to it. So those are some of the innovations that are in progress. Some other things we're looking at, point-of-care testing. I know this is being done in other parts of the country using iStats or a similar device. We're currently looking at the Chem8 Plus cartridge that's CLIA-waived, mainly to meet the requirements of the heart failure physicians. If we can get the BUN, creatinine, and potassium levels along with our examination with the patient, we can do more and more home diuresis and keep the patients out of the ED and get them rescheduled for their appointments. We've done some of this already, but we need to standardize it. So we're looking at those protocols and base some point-of-care testing to make it safer. The SNFs I mentioned earlier, the skilled nursing facilities are starting to come to MIH providers. We'll be entertaining some of those ideas to see if there's a gap and transitions of care along those same lines.
So from a payer perspective, I think we're starting to hear this more and more. We really need to stop thinking about EMS and the emergency side. It isn't just the emergency transport only. This is actually using pre-hospital caregivers and, and what we consider the outside the traditional means. Community-wide, we're all healthcare providers, and I think as MIH develops larger and larger, there's an appreciation that's developing within hospital systems and payer groups of let's utilize this workforce to its best. And here in Oregon, we're really trying to, have an apple-to-apple comparisons to what community paramedicine and MIH looks like. So when one hospital system in, let's say, Portland looks at another other hospitals in their system in other parts of the state, when they're talking about MIH, they're all talking kind of from the same page. So from the payer perspective, we're looking forward to this and really hoping this develops into, a long-standing engagement with the EMS workforce.
We found that as you venture into the healthcare world outside of EMS, people don't think of EMTs, paramedics as healthcare providers. The picture that's on there is my 5-year-old son trying to get a kite up in the air, and just behind him, it's not shown, is a orchard. And there's a lot of wind coming off that orchard, but he's in that dead space. And it took a lot of work to get that kite up into the air that's coming, a little higher than the dead space. And I like to use that as an analogy because I had to go to a lot of meetings. Many of us would be the only uniform out of 400 people at a conference of community health workers or payers or, where healthcare decisions are being made. And they look at you and say, what are you here for? First they thank us for all the 911 business we do. Then you tell them, say, we're seeing the same patients and all the benefits of mobile care, that we have medical direction, we have quality improvement, etc., and we should work together. And they're smart people. When they see that, now they've become our best advocates. And people like Paul and many others are now starting to call us up at various providers and say, hey, is there something we can do together? And the numbers are starting to come out for them. So it's an exciting time to be working together. I think that is all that we currently have, Gary and Kevin. I don't know if there's any other questions to be answered or what we can provide for you now.
Well, all I can say is amen, and what a breath of fresh air. And I think that was a wonderful presentation. I think the approach that you're taking in Oregon is certainly one that I think we can learn from around the country. I will open this up to questions momentarily. I just wanted to ask one question and follow up to that, and that is a lot of community paramedicine programs are very local. They have risen to address one or two isolated needs within a community, and that's fine. They're supposed to address different needs in different communities. Or they are working with a particular health provider, hospital, maybe a health system, or they have one single payer that has an interest in a population in that particular geography and wants to do something. Do you have advice for sort of all of the rest of us who are following that kind of model of, bit and piece development around states for making it a larger, more regional approach to MIH or CP development? How do we do what you do?
Well, I always jokingly say I put people in a room and I feed them, and so they'll be able to talk about it. But I think that really is part of it, is open up the opportunity for people just to meet each other and have an understanding of what they do. I think Mark really outlined it, as there's not a real clear understanding outside of the immediate EMS community about really what is EMS about. When HealthShare convened the first large group, it was kind of an all-comers, let's just learn what we all do together. As Oregonians, we tend to be a little more on the pioneering spirit and willing to kind of do things collaboratively, but I think it can be done in other parts of the nation quite easily. Getting champions is key, whether it's a payer champion or a healthcare system, and hopefully representatives of each of those groups. It's being willing to burn a few bridges and maybe look at some new ones, to get out of our silos and look beyond and take some risk. We know that this is going to cost money up front, and we know that downstream we're going to have some cost-saving benefit to this. So, be risk takers. Engage where you haven't engaged before. I don't know if Mark or Charmaine from your perspectives, if there's a different thought about that.
It is key to get your players, everybody on board. And it's taken a lot of work. I know we've been pounding the ground for about 10 years on some of this, but bringing that initial summit together is helpful. If you have an ACO, where we are CCOs, if you have an ACO structure within your state, some large group like that is already networked, and you have central care case management, would target those areas because that's where the difference gets made. And we're not needed everywhere. Some places the resources are very adequate in taking care of it, but there's so many places that need our services, and they just need to hear about it. And once you get those champions, then they're out there doing, shaking the doors for you, and you just have to hang on it because the business will start coming.
And I think that collaborating with your other EMS partners has been really successful for us. Getting the fire departments working together with the ambulance companies, and so that private-public partnership has worked really well. And just, not being afraid to talk to your neighbor and seeing how you can work together and create these programs and, create consistency as well.
I think that's really been helpful for us as this has gone beyond the Portland metro area. So many projects feel they're working by themselves because it is such a localized effort, but when they realize someone else has already been down the path, we have, as we mentioned in our work group structure, we meet on a monthly basis, and it's an open opportunity for folks to come and share best practices, to talk about challenges. I've even gone so far as I have the CCO groups meeting separately just to have a better understanding about EMS and how to engage with this, and that seems to be working really well too. But I think, as Mark said, this has been a long path to get to where we are today, and it's a lot of work. But don't be afraid. Go meet your neighbor.
Yeah, don't be afraid to find new neighbors. In the last month, I have seen some Medicare Quality Improvement conferences presented at. Some heart association groups, some skilled nursing collaborative groups. You just have to start looking outside the box to educate folks. And sometimes it's competitors, sometimes they become your best partner.
Great. Gary, do you want to unmute everybody and give people an opportunity to ask questions?
Okay, I'd like to take just a second if I can before we unmute Kevin. I did some work with the University of Washington over the last couple of years, and the Journal of Healthcare for the Poor and Underserved in this month's issue has published an article in the supplement about the rural community paramedicine programs in the country. And it's copyrighted, so I can't distribute it to everybody, but if you have an attachment to a university or a hospital, it's, I think, well worth trying to grab. It talks about what the existing rural ambulance services are doing in relation to community paramedicine. And one of the more interesting facts, you guys talked about home health quite a bit today. One of the more interesting facts that came up is 39% of the rural agencies in the country are both receiving from and giving to referrals to home health agencies. I think that's a stellar number. Wasn't expecting that kind of a result, but there are some nice tidbits in that article. Okay, now I'll open it up for questions. I'm going to unmute everybody.
The conference has been unmuted.
All right, I see everybody in the green. Are there any questions for our panel? While the juices are flowing, how does the arrangement work with the ride-sharing organizations? How do they get paid, and who does it?
Mark, you want to start with that, or you want me to start?
I'll probably mention the contract piece. For our agency, Tualatin Valley Fire and Rescue, we actually have. For many years, have had what we call the $100 fund, that any crew at any time can meet a patient's needs, whether it's transportation or the need of medication or groceries in their kitchen. So we have done that at times for transportation. If they're specifically Medicaid and they're an MIH patient, then we work through the channels that are already there that Paul can explain.
Yeah, as I mentioned earlier, a benefit that's provided by the CCOs in our reporting area, and mainly most of the CCOs in our state, is a non-emergent medical transport benefit, which is free transportation for any Medicaid member in the state. But that said, our particular geographic area, it's incredibly well used to the point that we have 125,000 transports per month. So sometimes if it's 3 o'clock in the afternoon and you need to go to a doctor's appointment or to urgent care or just to be moved, it can be quite difficult. Or geographically, it could be a challenge in some of our more outlying areas of our counties. We're starting to look at options with ride-sharing opportunities, particularly in the inner core, just because there's such a high concentration of providers in that area. It's a new one for us too. So, innovation can be good and bad at this point. We're looking at a very limited scale for our folks because we do have such a robust non-emergent medical transport brokerage process. But time is everything, and if we can get, particularly if we don't have to have somebody transported in the 911 system for something that could be handled in a non-emergent way.
All righty. Thank you. Other questions from folks out there?
Hi, this is Howard Becker in California. You mentioned that you did not change the scope of your paramedic practice, but the role, and I might have missed it if you had to do any legislative change, but what does your statute say in terms of the allowing paramedic practice, and did you have to make any changes to that?
We do not currently. When the statute opened about 5 years ago on a different issue, looking ahead, it was pretty tight around language of, pre-hospital and 911 response only. And we were able to, at that time, insert some language just under the non-emergency care definition that allowed us to function, where we would not be tied like California. I know with Dr. Amy Mullen I was discussing with, that you had to have a waiver because of the way the language was. In Washington is similar, but not quite as tight. But it all comes down to the scope of practice in the individual state language that you have to look at closely to see if it allows it. In Oregon, we're able to do it. It doesn't call out and say a community paramedic is, and here's what he or she does. But it's not illegal, it's not disallowed to function within our scope as long as we have a medical director and an agency and so forth. We function under the same rules. We all recognize we do need additional clarifying language in the future to make this more permanent and answer people's questions.
Other questions? Okay.
Kevin, can I do a plug before you hang up?
By all means.
The 13th annual IRCP meeting will be in Warwickshire, England, February 9th and 10th. And we have 33 speakers covering 22 topics. And for the first time ever, the research is dominating the agenda of IRCP. And we also have a couple of presentations around standards that have been or are being developed. So that's sort of an exciting change for us to go from evaluation to research as the dominating part of IRCP. The Association of Ambulance Chief Executives is supposed to open up registration this week. If you're interested in attending, you can go to ircp.info and get more information. And once the registration link is made available, we'll link it from the website. So I hope to see a few of you there. Thanks, Kevin.
Well, thank you, Gary. I'll just remind folks that this program will be archived with all of our other previous programs and accessible through cpif.communityparamedic.org. Thanks to good graces of Gary Wingrove and Clear in helping us to keep the technology on this rolling along, and a track record on our past 5 years of CPIF programs. We will not have a program in December. We will start again in January and celebrate the beginning of 2018 with a new series of Community Paramedicine Insight Forums. So for the National Association of State EMS Officials, and the National Organization of State Offices of Rural Health, and the Center for Leadership, Innovation, and Research in EMS. I want to bid you all a happy holiday season, and we will look forward to seeing you in January of 2018.